There will be lots left. You don't need to worry that there won't be anything left. All right, so our next speaker is Dr. Camille Williams. She's the senior lecturer at the Questions for Cancer Doctors. She grew up in Jamaica, and shortly after graduating from high school, she immigrated to the United States. She enlisted in the United States Army as a nuclear biologist and chemical specialist, where she was quickly recognized for her leadership, athleticism, and academics. She continued her education at Rutgers University in New Brunswick, New Jersey, graduating in 1999 with honors bachelor's science in biochemistry. And she then went on to medical school, followed by residency training in radiation oncology at Northwestern Memorial Hospital in Chicago, Illinois, where she also began her cancer advocacy work in 2004. Outside routine clinical practice in radiation oncology, she promotes advocacy and awareness in an effort to reach a greater population and address the health disparity in cancer. She works closely with the American Cancer Society and is a member of the Prince George's County Leadership Council in Maryland. She's the senior lecturer for the physician group at Questions for Cancer Doctors, LLC. Their website is www.questionsforcancerdoctors.com, which is a patient education company. Her other work includes past appearance on the syndicated Tom Joyner morning radio show Wellness Wednesday, Dispelling Cancer Myths, and she also did a period on the Dr. Oz website, ShareCare. Additionally, she is the founder and president of Our Kids First, a nonprofit organization that focuses on exposing youth to various career options, including untraditional non-degreed and degreed programs. At the heart of everything she does is empowerment through education and advocacy. Today, Dr. Williams is going to talk to us about best practices before and after cancer treatments. Ladies and gentlemen, please welcome Dr. Camille Williams.
Well, good afternoon. I think, nope, still good morning. Good morning, everyone. Thank you for toughing out through the call for lunch. It's hard to be the speaker between lunch and talking about cancer, but thank you so much for staying, and thank you so much for that lovely introduction. I've been here this morning since the first presentation, and I don't know if Dr. Barsom or Dr. Gatliff is still here, but they did a lot of the heavy lifting, right? They spoke about the science behind diabetes and the science behind obesity, and then Dr. Gatliff took it and talked about the mechanism behind obesity. And as they were speaking, I was thinking to myself, well, I think I may have covered some of those. But my bend is towards advocacy. It's more towards those who are non-scientific, who don't practice medicine. There's stuff in there for the medical folks as well, but my bend is towards advocacy for those who are not usually within the medical field. So with that being said, I'll be talking to you about best health practices. I have no financial disclosure. As an overview, I'll be covering cancer statistics, best health practices, common chronic diseases and their association with cancer, nutrition and cancer treatments, and some common myths associated with health and cancer diagnosis, particularly as it may pertain to those who live within the Caribbean. So let's start by talking about some cancer statistics and try understanding why cancer really matters, and build upon what was presented this morning by Dr. Barsom and Dr. Gatliff. So why is cancer information and education so important? Why is it that every time you turn around, folks are talking about cancer? That's because 25% of people will be diagnosed with cancer in their lifetimes. Depends on how you like to receive your information. That's 25%, 1 in 4 people. Look around and count 1, 2, 3, 4. It's very prevalent amongst us. So, regarding estimating new cancer cases in the United States, what we're showing here is the differences for different cancers for both males and females. You'll see for males, the incidence is surrounding with prostate, lung, and colon, while for female, the incidence is with breast, lung, and colon. So the difference between the two usually is between breast and prostate. However, why this is even more important is not about just the occurrence, which is the incident, but the mortality. How many people are really dying from this, and what can we do to prevent or make a change in that? So the leading cancer diagnosis in women shown here, is lung cancer. We hear a lot about breast cancer, but that is not the leading cause of death. It's still lung cancer, and that's followed closely by breast cancer and colorectal cancers. Now, the other cancers that are listed there, you've heard about the pancreatic cancer, the ovarian cancers, which was covered this morning, non-Hodgkin's lymphoma, amongst others. But again, the leading cause is lung, and we'll talk about some of the causative reasons as to why that is still the leading cause. Now, within man, it's the same thing. The cancer mortality, lung cancer is the leading cause of death, followed closely behind with prostate cancer and then colon cancer. And we share the same thing with men as well. It's the same thing with pancreatic cancer, liver, leukemia, esophageal cancer, etc. In the United States, and again, a lot of these statistics, as we heard this morning, is very much akin and similar to what's in the Caribbean. So in the United States in 2016, last year, we have over 1.5 million folks who were diagnosed with cancer and 595,000 cancer deaths. Now, if you break that down as the American Cancer Society did, every day, 4,620 people hear the words, "You have cancer." And even more alarming, over 1,600 people die from cancer. So this is important for us to have an understanding of the importance of cancer. So then I take a deeper look at what's going on in the Caribbean, and a lot of the information that I received was from the Pan American Health Organization and from the World Health Organization. As you know, because the Caribbean is spread out so wide and the population is so small, we have to group all the information and use the statistics the best we know how. And again, I'll put a push in to say that the registrars are there for that reason. If no one registers about having cancer, then we don't know how best to serve the Caymanians and those who reside on this island. So I'm going to give my push as well to encourage those who are here to encourage patients to register. And as you can see, cancer is a leading cause of death, still remain the same. And in 2008, it was 1.28 million deaths from cancer, 45% of which occurred within Latin America and the Caribbean. And that number is set to increase to 2.1 million by 2030. So you'll be doubling the cancer death rates. We have to do something about this. Among the Caribbean males, as you see here, prostate cancer is the leading cause of death, followed by lung cancer. In the Caribbean, the prostate cancer deaths is led by Suriname with 18.4%, followed by the Dominica with 47.4%. For females in the Caribbean, breast cancer is the leading cause of death, followed closely by cervical cancer. So for the breast cancer leading cause of death, 14% is in Belize, and the Cayman Islands made the statistics over here in the bottom. As you can see, 29.7% of the death per the WHO from breast cancer is noted here in the Cayman Islands. So there is something that we need to do to make a change. So I went on to the Economics and Statistics Office to get a better understanding of what's been going on in the Cayman Islands. And they listed here the top 10 leading cause of death, which may be a little small print, but what I want to focus on is the top 3. And that shows that, again, disease of the circulatory system, malignant neoplasm or cancer is the second, followed by disease of the respiratory system. And the total all-cause for this compendium from 2015 was 170 deaths that occur. But again, cancer is right there, number 2, with 48 of the deaths. And then they split it between male and females, the percentage of deaths here in Cayman Islands. So I went back a year to take a look to see what else is happening, and the total in 2013 number of deaths was 172, and 35 total was from cancer. So there is a steady increase here within the Cayman Islands from those who are dying from cancer. The question was, as I went through the statistics, I was not sure at the time how many were Caymanians versus non-Caymanians, but again, the number remains the same, and that is why registration is so important, so that when we talk about, as visiting lecturers, we can be more into the nitty-gritty and present the information that's important to you as residents and Caymanians here. So again, why is cancer so prevalent? Why is it that one of the top 3 throughout the world that it's cancer is a cause of death? There are a lot of information saying, well, maybe it's because we're able to diagnose cancer sooner. 30, 40 years ago, we did not have the mammograms like we do today. For prostate cancer, we didn't used to do the PSAs as we're doing. So we are catching the cancer earlier, but still the death rate is going up. So why is that, and what can we do to change that? As I look throughout the Caribbean, being from Jamaica myself, I am very much aware of some of the reason why the cancer rate is that high. One, it's the diagnosis can be late in the Caribbean because of limited access to resources for some conventional treatment, prohibitive cost, poor baseline health, some associated with chronic disease that I will review. And of course, there's always the psychosocial issue, the psychological portion of it where no one really wants to say the C word either. They don't want to talk about cancer. So given the high cancer death rates in the Caribbean region, many are seeking alternative. And that's a whole nother lecture, but I know that folks tend to turn to their herb supplements and things when they're diagnosed with cancer instead of going the conventional route. But unfortunately, when that's done, patients tend to come back to me later with more progressive advanced disease. And so I tend to ask my patient as a midway to say, okay, if you want to try some merengue or some other herbal stuff, fine, but let's at least start with the conventional treatment that we know works and works well. May be toxic, yes, but we know how to manage some of these side effects. So, food for thought. What are you willing to do? What if there's something you could do to prevent certain cancers from occurring? Would you do it? If there's something you could do to decrease your chance of getting certain cancers, would you do it? Yeah? If there's something you could do to help you live a longer, healthier life, would you do it? So we're going to explore some of that, and here we're talking about healthy living. It's a lifestyle change, right? So they talk about fitness and nutrition, positive thinking, and eat first. Some of what's been covered between last night and today. I've been told that here in Cayman Islands that you already feel good. That's in the bottom blue. And that the stress is very low. But we still have to work on the other 6 parts. What, that's not true? The stress isn't low? No. Okay, so if you ever come to Maryland, D.C. area and you sit in traffic, you'll see what stress is like over in the States. This is really nice and relaxed. I'm loving it. So, you know, there are some things that we need to do. And again, I'm going to bend a little bit more towards the non-scientific. So we're going to talk about best health practices. I put before cancer in parentheses because this should just be best health practices, period. Right? No one wants a plan to have cancer. One of the statistics I say is 1 in 4 that get cancer, but remember, the 3 others didn't. So how about we work to try to be in the statistics of the 3 if we can do something about that. So let's talk about living a healthy lifestyle, right? So you said that if there's something you could do to prevent certain cancers from occurring, that you would do it. So let's talk about what cancers you can prevent. You can prevent colon cancer, right? Colorectal cancer is the 3rd most commonly diagnosed cancer in both men and women, as I showed you initially. It's usually known as colon cancer, but it's the 2nd leading cause of cancer death when men and women are combined. Now, we can prevent up to 50,000 colorectal cancer deaths that can occur each year. Yet, more than 1 in 3 adults in the United States is not doing what is necessary to prevent colon cancer. So the best way to prevent colon cancer is through screening. And there are many screening options available. And I'm going to say it now, you'll see it again, but a colon cleanse is not part of the screening option, right? There are many screening, a colonoscopy, you have the flexible sigmoidoscopy, and what this is just showing you here is what a colonoscopy does. It goes through the entire length of your colon. So the prep is going to have you empty out your bowels, get rid of all the stool, so they could use the scope to see what's going on. And inside, this shows what a normal colon look like. Don't forget my audience over here. But over here, you'll see a sessile polyp, meaning it's flush with the lining of the colon. And then on this other side is a pedunculated polyp, meaning it's hanging off like a grape. When you do the colonoscopy, you're able to not only see, but you can remove some of these, right? And so when it comes to colon cancer as well, one of the things I want you to notice here is that sporadic cancer accounts for almost or over 70% of the colon cancer cases. So it's not genetics, it's not majority of it, it just happened. As they said this morning, I hear them talking, it could be just the card you were dealt. So we want to do what we can to prevent colon cancer. So what are some of the things, what can you do about this? This is showing you here different stages of the colon cancer. That first green arrow is pointing to stage 0. That is where you're able to really do something about it. It's small, it hasn't spread anywhere, it's early. You get a colonoscopy done, they could likely remove that, no problem. No chemotherapy, no surgery, no nothing, you're done. However, if you decide not to do anything and just stick to your cleansing all the time, and there's a polyp or something there that wasn't removed and it progressed, then you'll see it becomes more invasive and it can spread to other areas as well. So what I'm trying to show you here is that you can choose. You need to get your screening. So the other question folks always ask, so, well, doc, well, what screening? When should I get my screening? What should I do? Last year, the Pan American and WHO got together to try to put a screening recommendation together for the Caribbeans because there's not one currently existent. We have screening available recommendations for the United States and Canada and the UK, but we don't really have anything for the Caribbean. But if you notice here, they tell you the frequency of when to do which test. Now, if you do the stool DNA, which I've seen advertising on the television where you're sending the stool sample and they test. Now, what they're testing for is to see if there's any cancer, if there's any DNA that's showing that there's blood. But if there's a polyp there or something, you can't really visualize it during a stool. So I always encourage folks that at some point within the first 10 years of recommendation to get a colonoscopy, just get a one-time look to see what's going on. But of note here, in the colonoscopy, if you have a normal colonoscopy, 10 years before you have to go through it again. So it's not a problem, you just leave that there. Now, I talked to my GI colleagues and there have been a change and a shift of recommendation of who should get colonoscopy when. And for African Americans or Blacks, Caribbeans, they should actually start their screening at age 45, not the 50. And there are a lot of genetic implications for those who are from the Caribbean that tends to have certain things more prevalent for them because they're Black or from the Caribbean or African descent, and we just don't know the reason why yet. We just know that it exists. So if you know someone over 45, they should consider getting one of these screening that's existing here from the US or from the UK guideline, et cetera. But we, I guess, here need to decide which screening guideline you'll accept until there's one established for the Caribbean. The other one that you can prevent is cervical cancer. Cervical cancer has, just like colon cancer, a very long period where you're able to do something about it. You can have your pap smears done regularly. Now, I know Dr. Gatliff spoke this morning about the HPV and the virus, and there's been in the news that now there's a HPV vaccine, et cetera. HPV has been proven to cause cancer not only for cervical, but also for head and neck cancer, for oral cancers, et cetera. So it is important for cervical cancer, you can prevent it, and that would be to getting your pap smear on a regular basis. What are the symptoms of cervical cancer? Usually, if you do what you're supposed to do and get your pap smear, there won't be any sort of symptoms, right? Because they'll catch it at an early stage. But if you don't have your pap smear and you have the HPV and it progressed, then you'll start to have some postcoital bleeding, which is bleeding after intercourse. You'll have some vaginal discharge and pain. And as it continues to progress and the disease get more progressive, you can experience low back pain, swelling of your leg, and develop that triad of sciatica, pain leg edema is swelling, and hydronephrosis, which you won't be able to see, but that's just a backing up of the urine where it goes up from the bladder and start to affect your kidneys. So we don't want that to happen if we can do something about that. So in the US, we do again have our recommendations about screening, and for cervical cancer, the screening for women getting a pap smear start at 21. So as a GP, if you're having a young woman in your life, et cetera, you should have had a pap smear. Now, the frequency is a moving target, because every time I look at the gynecological recommendations, it may be every year, or if you have something abnormal, you do it every year, or if it's normal, it'll be every 3 years. Be that as it may, your doctor can give you information about what is recommended and when, and the pap test is one of the most important things. One of the questions I've always asked, when can I stop having pap smear? The big one is if you have a hysterectomy. If you have a hysterectomy, your womb is gone, there's nothing there to test. When you stop, on the other hand, though, is when you have to talk to your primary care about that, because if you keep having positive tests for HPV or having abnormality, then they will be able to tell you when would be the best time to stop. Now, this here is just showing an example of a cervical cancer progressing. What you're looking at the top here, this is just the womb, and the cervix is at the bottom here, and this is the vagina, the vaginal canal. And this tumor, it can grow in various ways for years, and folks don't have any idea. And cervical cancer is very prevalent in the Caribbean, second only to breast cancer when it comes to diagnosing this stuff. So remember, though, this takes many years to develop. So you can do something about this. Get your screening so that we don't have to get to this level, okay? Now, there are other cancers that there are screening recommendations for, and I just list a few here. Endometrial cancer was covered this morning by Dr. Gatliff. There's a lung cancer screening with low-dose CT scan. If you're a smoker, used to be a smoker, you need to talk about when you should start getting screening for that. Again, another thing, prostate cancer, they have here 50, but if you're African American or a Black or African descent, you really should start at 40. I encourage you to ask all the men in your life and all the men here, what's your number? And that's not phone number if the lady's asking you what's your number, it's your PSA. You should really know what your PSA is. It's too easy, it's just a blood test. And yes, you should have the rectal exam with it as well. However, if you can see what your PSA is, it's a number that you can follow over time. So if you're 40 and your PSA is 1.1, and then when you're 43, it jumps to 4, you'll know something is off. Additionally, the PSA differs by race. So the PSA in the Blacks versus whites versus if there are any Asians, it really differs. And so the point is to get across is to start and to know what your number is for prostate cancer. Then of course there is breast. I think I've been seeing too many young women diagnosed with breast cancer, and I'm usually laid back and cool, as most Jamaicans are, but I really got into a hissy fit when they were trying to change the guideline for when women should get their mammogram to 50 to start. And I was like, no, there are too many women I treat with breast cancer, even under 40. So to try to move it to a higher number was unacceptable. So a lot of us in the oncological arena, we put up a fight, and I haven't heard anything much about it, so we're still doing our mammogram screening starting at age 40, and it can even be younger if you have a family history. So if someone in your family had breast cancer when they were 45, or any cancer for that matter, you need to get your screening 10 years earlier. So if it was 45 that your mom or grandma or someone you know in your family that's next of kin had breast cancer, then you should start your screening at 35. So these are some common knowledge stuff that folks need to know and you need to share with others as well. So let's go back to what are you willing to do? If there's something you could do to decrease your chance of getting certain cancer, would you do it? Yes? Food for thought. Let's see what we can do to decrease it. Let's talk about some of the chronic disease and their association with cancer. Now, again, I'll be able to go through this a little bit faster because Dr. Gatliff and Dr. Barsom did a lot of the heavy lifting this morning, but I think it's important still for you to know your risk. We need change, right? The number, again, for cancer diagnosis and cancer death will be doubled by 2030. And about a third of all these cancers, as you've heard before, could be prevented by avoiding key risk factors, and these include the tobacco, harmful use of alcohol, and unhealthy diet, and other physical inactivities. So here are some of the things that are common chronic disease in cancer, bad habits in cancer, and I'll just cover a few of these because I know you know what these are. It's just a matter of getting you to do some of these things. So let's talk about diabetes first. I actually kind of like this cartoon. It's like, just to get a little jump start, like, okay, it wasn't really insulin, you don't have diabetes yet. Don't want to get there. So diabetes is damaging on many levels. A glucose level of 254 is not a good number by any standard. And when you start to get those foot ulcers and things are not healing right, imagine that's happening throughout your body with inflammatory process. And so this is something that was dealt with in depth this morning. And this shows here over time that if you don't manage your diabetes, you could lose your eyesight, the blindness. It messes up with your kidney. You could go on to dialysis. And of course, you have sores that can lead to amputation. So what are some of the incidents and the association with diabetes? Now, again, this is just an association. It doesn't cause these cancer. But if you have diabetes type 2, you have a twofold increased risk for pancreatic cancer, primary liver cancer, and as you heard this morning, endometrial cancer. Then also, you have increased risk also for colon and rectal cancer, breast, and bladder. They have not been able to do association for type 1 diabetes. So what about the cancer death rates? Is there an association? Yes, among women, either liver cancer, pancreas, endometrial, colon, and breast. And among men, I thought it was interesting that breast cancer is listed there, even though of all the breast cancer diagnoses, only 1% of them are men. It still has that it causes an increased death association if they have diabetes. Then there's the liver, oral cavity cancer, pancreas, and so on. So there have been studies as well that's been done that shows association of diabetes and cancer, and this was done in the Hong Kong Diabetes Registry. This is amongst a culture that usually are considered to be healthy and have a long lifespan. Now they too are afflicted with diabetes as well. So it's a change that's seen throughout the hemisphere, throughout the world with this increased risk in diabetes. And so they've been doing studies that show that if you have diabetes and you're diagnosed with cancer, you have an increased risk of dying just because of that as well. So next, we want to take a quick look at maintenance and obesity. So how do we define obesity? That was previously covered, but one of the things I want to point out here is that as you look at the body mass index, in Jamaica, if you're here, them say you're scrawny, right? If you are somewhere in the normal range and have any muscle tone, them say you're tough. So I'm been told in the Caribbean that they like the woman to have a little meat on their bones, but how much meat do you need to have on your bone? And to what end? You know, it can be damaging. This here is showing you the body mass index, and it was discussed this morning as well. And if you're into numbers and how to calculate it, it shows you here how to calculate your BMI. And they're giving you an example of a woman here who's 5'5", and what's considered underweight, what's overweight, obesity, and extreme obesity. If you're not into numbers and just want to find what your weight is and your height, there are graphs also available, and this is for the woman. You could find your height here on the left side, and then find your weight across, and it'll tell you what your BMI is, whether you're underweight, you're good, you're overweight, or if you're in the obese section. Now, this also is available for men as well, and it shows here, go back here, it shows here that for this person who is 5'9", weigh 189 pounds, that their BMI is 28, so they're overweight. So it's a simple way to just look in a graph real quick to see where you are. Or you could do like Dr. I think it's Gatliff this morning, talk about the waist size, just measuring your waist, right? So there are different ways for you to know. If you need something to jerk you into getting something done, find whatever works for you. It's different for everybody. So now, what we need to know about obesity and cancer. Now, that was covered quite a bit, and more on the gynecological side. But cancer, after smoking, obesity is the next thing that's give an increased risk for cancer. And here is showing you what overweight. And notice I didn't say just obesity. It says overweight and obesity. So someone could be overweight and look just fine. You have to look to see what your BMI is. But if you're overweight and or obese, you have an increased risk for all of these cancers listed here: esophageal, gallbladder, kidney, colorectal, endometrial, pancreatic, and of course postmenopausal breast cancer. And it says that in the US, 117,000 cases of cancer every year is associated with excess body fat. And yet 7 in 10 Americans are currently overweight or obese, so 70% of us in the US. And less than half of Americans are even aware of this link, and that was when discussed this morning. So again, it says here, protect yourself, move more, eat smart. Now, I look at the information that we have for the US, but there's also information that's associated with overweight and obesity for the UK. So it's a problem that's within a lot of countries here, and these show the number of cancer causes by being overweight. And in the UK, they're actually able to list the numbers that it's associated with. So breasts have an increase of 4,300, for bowels, 5,400. So they're trying to make a change in the UK as well. So why is obesity associated with cancer? Dr. Gatliff did an awesome presentation on that this morning. But I just want to put this up here that there's a genes, a diet, and so there are things that you can do to navigate through and try to prevent some of these diagnoses. So obesity can delay cancer diagnosis. So I wanted to pause here for a second because in order to diagnose cancer, there are certain tests that has to be done, and especially if it's anything that's GI related, we need to see inside the body, see what's going on. One of the first and most common tests we do is a CT scan or an MRI. But if you can't fit through the CT scan, we can't get in to see what's going on, right? And if you're too obese, it actually kind of changed it actually changed the quality sometimes of what can be seen, because then the radiation have to travel through many layers of fat, and sometimes it gets distorted. Additionally, there was a weight limitation. Back about 10 years ago, the weight limitation was around 300, and now they had to increase it to over 450 plus to try to accommodate some of these patients, not only for CT scan, but for MRI. So we have a big issue going on with weight. So think about this. If you are sick and there's something going on, wouldn't you want to know, right? We're limited if you are obese and you can't fit through the machine. And if you do an MRI with an open MRI, it's still not the same quality. And any radiologist will tell you that they prefer a regular MRI. So you'll be delaying your cancer diagnosis. I know we like to have a little meat on our bone and be curvaceous and stuff. That's great and all, but not to the extent where it impedes your health. All right. So use of tobacco products, this has been preached over and over again. I'm still amazed at how many people still smoke. Or they'll say, well, I'm not smoking cigarettes, I am dipping or I'm chewing, so it's not the same thing. Not true. You're smoking a little cigar. Now they have the flavored cigar. You walk in, smell like chocolate and strawberries, and it's still putting you at risk for cancer. So this is just showing you here that cigars contain larger quantities of the same harmful substance as cigarettes. One cigar can contain as much tobacco as 1 pack of cigarettes. So that's a lot. You know, sometimes, okay, we're going to the smoke, we're going to do our cigars and stuff, and pipes is the same thing. It causes just as much problems. So what's in a cigarette? I'm sure you have seen this one before. If you have not, here's what they're smoking. Lighter fluids, battery, candle wax, barbecue lighter, insecticide. They're smoking toilet cleaner, rocket fuel, paint, carbon monoxide, and arsenic poison. Another, a twist to killing you softly, right? Methane, which is like sewer gas, and acetic acid, which is vinegar. Now, all of that stuff is compiled up in a cigarette that they're puffing away and putting it in their lungs. Now, we're all about recommending to decrease smoking and to stop your smoking, and this here shows you some of the smoking, direct smoking, and what secondhand can do. And you'll see here, maybe a little bit small, but the cancers associated with smoking is the larynx, oropharynx. These are all in the back of the mouth and by the throat. The esophagus is the swallowing tube, the trachea and the lung, which is the breathing area here, the stomach, pancreas, kidney, colon, cervix, bladder. So what all these poison do, even though it's going in through your mouth there, it actually is messing up with your DNA. It's a carcinogen, right? So it's causing your DNA to not be able to repair itself, and that's what leads to the cancer. So anywhere it can go and cause damage, that's what it's doing. And we know it also causes a lot of chronic diseases, stroke, some with blindness, aortic aneurysm, to name a few. Most importantly, though, is the secondhand smoking that's still a problem. You know, I see people driving and the kid is in the car and they'll open the window and they try to blow it out while the wind blow back the cigarette smoke in there into their child's face, putting their children at risk for all different type of things. Now, the blue is saying that there are evidence of suggestive that it may cause these, while the evidence are known for the ones that are in black. So for children, you may be causing some brain tumors, some lymphomas, cancer, asthma, breathing issues. And for adults, it's the same thing here. Coronary artery disease. We know about lung cancer for sure. And of course, there's reproductive effects and issues for those around you. And this is secondhand smoking, not the primary one. Alcohol is also a group 1 carcinogen. Before I move on, there's one other thing I want to make a point of. I had a patient the other day that had a CT scan done after he had radiation for a small lung nodule. And in the report, it said that in the left upper lobe, there are radiation changes from the treatment he's received, but on the right side of the lung, that there are airway diseases from injury. And I went through the report with him, and he said, well, I stopped smoking like 10 years ago. Why does it mean that injury? I'm not smoking anymore. And I said to him that the smoking you did 10 years ago is what's causing the injury now. So if you are an athlete and, well, you know, all Jamaicans, we don't believe in paying for school or any of that stuff. So, you know, back in the days at Rutgers, I was on the track team, and, you know, I did all the hurdles and the sprints and everything. But all that beating up on my knees and the running now is having an effect. I won't tell you how many years later. but it's starting to have an effect now, and you can have the effect later on in life. So it's not an immediate thing, it's an ongoing. Now, we encourage people to stop smoking, yes, but know that sometimes the damage is already done. That's why people have the COPD and the emphysema. You can't have that exchange anymore, and so that will always be seen on a CT scan. So alcohol is also a group 1 carcinogen, and there's all these debates about, can I have a glass of wine or two, or, but it's this excess, right? If you have, when you wake up in the morning, you need an eye opener, that may be considered excess drinking, right? If you go into the hospital and you're admitted and you start having the shakes and stuff because you're going to withdraw from not having your noon drink, whatever it may be, that's a little bit on the excessive side. So a lot of folks doesn't talk about alcohol anymore. As my dad would say, people got to have a vice, right? And I'm like, well, not really. So everything, you don't have to drink all the time. But just like tobacco, alcohol is a carcinogen. And this is a slide from the UK that's showing the cancers that's associated with alcohol: the mouth and upper tract, the larynx, esophagus, breast cancer, liver, and bowel cancer. And so, again, the way that alcohol causes cancer is by damaging the cell, increased damage for tobacco. So imagine someone, they drink and they smoke. They're setting themselves up for all sorts of stuff, right? So we just want to curtail that, and they said 7 cancers that this can cause. And just a quick push for the sedentary living. We're getting bad. We're getting so bad, y'all. Some transition occurred right here, I'm not really sure. And I thought this was pretty cute and funny indeed. But we're finding that a sedentary lifestyle is getting to be just as bad as smoking. A lot of time people go to work and they sit at their desk. We're no more intellectual. We're not in the farm anymore and tilling and things of that nature. So we go to our desk and we sit and we work. We're an accountant, financial stuff, and we're just mentally engaged and we don't move like we should. And so that's becoming an issue too, and it's showing that sedentary lifestyle, you get home, you're tired, and it's contributing to all of these things that we discussed earlier: the obesity, diabetes, heart disease, stroke, and eventually leads to cancer. So we need to get up and move, and that's my one little pitch about that, because self is guilty sometimes, but the patients keep me running around the clinic, and I got my Fitbit, so I was like, see, I'm not doing too well today, so I have some catching up to do. So now let's talk about nutrition and cancer treatment. Right? You have to be prepared for the battle. No one wants to have to deal with cancer, but the emphasis is that should you have to deal with it, you want to make sure that you're in the best possible physical situation to deal with it. So the triad for cancer treatment, there are many different new types of cancer treatment that's available. It's a surgery, chemotherapy, and radiation therapy. And we're just going to talk a little bit about nutrition and screening, and then more about what these side effects, the side effects from these treatment can do if you're not healthy going into treatment. So we try to do a nutritional screening, or we recommend a nutritional screening for patients who are newly diagnosed with cancer. And there is a patient-generated subjective global assessment that's usually used. And nutrition during cancer treatment is something that we're all trying to get better at. Now, some of my patients, they see this and they said, well, I can't live off tomatoes and green juice and cauliflower and romaine. Like we were taught yesterday by the foodie doctor, the foodie physician, and we talk about doing the farm thing today. It's all about how you prepare your plate, and we'll talk a little bit more about that. It doesn't all have to swing the pendulum to the complete other end and say, well, because I was eating a Burger King and fries and now I'm diagnosed with cancer, I'm just going to eat all green leafy vegetables. You still have to maintain that nutritional content of your food. So nutrition is important for patients diagnosed with cancer because the studies have shown that 80% of people with cancer have symptoms or sign of malnutrition. 40% of people with cancer may die sooner due to malnutrition or complications due to malnutrition. And as was noted this morning, obesity does not equal good nutrition, okay? So we need to promote best health practices, and that may help patients have a speedier healing process, tolerate the side effects from the cancer treatment better. And the common side effects is really just based on where you're treating, where the cancer is, and we'll get into that a little bit later. And again, for good nutrition, it's important for patients because when you have cancer, it changed the way the body uses food. You need more energy. A cancer treatment may affect your nutrition. You may become anorexic, meaning losing a lot of weight or not wanting to eat. And it's important to treat weight loss caused by cancer and its treatment. So I'll tell you, if I'm treating someone for like a head and neck cancer, the minute they get 10% of their presenting weight loss, we try to give them some nutritional through a PEG tube, because maintaining nutrition is important for getting through treatment, especially when it's chemotherapy and radiation combined. So this here is just a quick look at one of the assessment tool that's used in the oncology realm for the physicians who are here. This is something that you can use within your clinic. And the study really just showed that the patients that they look at, 4% of them were well-nourished, only 4%. The others were either moderately or suspected of being malnourished or malnourished. So that goes to show that even though we're eating, we may think we look right and okay, you're not in a good nourishable status. So this was developed to help patients and as well as their physician have a good idea of where their nutritional status is, so we know how to better show and tell patients how to eat during the cancer treatment process. So this is just showing you here, it's big, I'll zoom in, what this patient assessment guide look like. The top part is for the patient and the bottom part is for the physician. And looking at the top part that the patient fills out, there are 4 areas that we ask patients about. Their weight, there's a history of did they lose weight over the past month or 6 months, and for some cancers you lose weight more than others. So if you're looking at pancreatic cancer, stomach cancer, you'll probably lose more weight than if you have breast cancer. The second one is your food intake. Did you change the way you eat lately? Because we want to know if you've lost any weight as well because of the cancer diagnosis. The other one, the third box, is the symptoms, and then the fourth is activity. How much activity are you getting out as far as expenditure goes? Then the bottom part is where the physician fills out, and the bottom box is where we are able to say what your nutritional status is. And that will also help us to give us a better idea of where to guide you when it comes to eating during the cancer treatment. So let's talk about when you're going through the surgery and if you have some of these diseases, what the problem would be. So cancer surgery really just depends on where the cancer is. So breast cancer surgery will be different than if you have esophageal cancer, if surgery is indicated, or lung cancer, or endometrial cancer. But the big thing is that if you have diabetes or active smoker or obese or have excessive alcohol intake, the issue with diabetes is that if you have to have surgery, we know that you're going to be a slow healer. If you're obese and have diabetes, then you're going to be in the hospital longer, prone to more having infection if you're in the hospital longer. If you are a drinker and we have to put you for surgery, then we have to talk about anesthetic risk. And so all of this comes into a bigger picture as far as, well, where are you in regard to having your surgery? And if you're a smoker and you're COPD and you may not be a surgical candidate actually, if your PFTs, which is your pulmonary function test, is low, it's showing that you are not getting enough or adequate oxygen. So no one wants to put you on their surgical table if the risk is high. So that's some of the reasons why these diseases are so important, because it may limit the treatment that you may get if you're diagnosed with cancer. The other thing we look at is chemotherapy. We know that chemotherapy, I tend to tell my patient, it goes everywhere in your body. If you have a blood vessel there, chemotherapy can go there. That's why you can lose your hair. But the cancer cells, the way that it works, the cancer cell is not able to repair themselves and come back whole again. They damage the cancer cell. The normal cells, however, is able to repair themselves, and that's why eventually your hair grows back, etc. But if you're not in a good nutritional status, if you're not healthy, if you're diabetic or active smoker or obese, the chemotherapy drug you're getting is going to knock you a 1-2 good punch. You need to be able to tolerate the treatment you're getting. If they have to give you any sort of a treatment that includes steroids, that's going to fluctuate your blood insulin level, your diabetes is going to be all over the place. You know, if you're obese going through this, it just makes for a difficult and more hard road for the patient who is going through chemotherapy treatment. So these are just some of the chemotherapy side effects: the mouth ulcers, the nausea, vomiting, the diarrhea, the cystitis, skin changes. Now imagine if you have folds and folds of fat on your body and you're having, you know, any of these like skin changes, and you could get an infection in these areas. So it's all important. Now to the best part, the radiation therapy, I call the healing beam. So I don't have time to be here to go through a lot, but hopefully I'll be able to come back and do a CME about radiation therapy and different types of cancer, especially as it pertains to breast cancer, et cetera. But with radiation therapy, this is showing here a woman that's being set up for treatment of breast cancer. And for patients who are diabetic or active smoker and obesity or excessive alcohol use, because of the treatment that we're doing for breast cancer, it may not affect as much because the treatment with radiation is outside of the body, meaning you could see where the pink traverse, it covers the entire breast. But if you have issues with your lung, there's sometimes as part of it goes to the lung, some of the radiation can get to your heart. So these are the things that your doctor will talk to you about regarding radiation. For men that have prostate cancer, we are treating in the pelvis. Some of the side effects from radiation includes, you know, the diarrhea, frequency in urination. If the patient is obese or have diabetes and they develop any sore elsewhere, the healing is going to be an issue, right? And if they're obese and there are any folds of their abdomen, radiation side effects like getting a bad sunburn eventually. So what's going to happen is they're going to have a bad side effects from having to burn, and then the healing is going to be a problem after the radiation is done. So we try to have that an issue. Again, this is probably hard to see if you're not understanding. This is an axial slice. This is where the belly button would be, so to speak, and this is the buttocks. Here is where the prostate is located, and it's just showing you where the radiation beam is going across. And this here, again, is another view. I like the sagittal view. This is the side view. It's showing you how the dose covers some of the rectum as well as part of the bladder. So it's like getting a sunburn on the inside. And so if you have issues with healing, this can affect your treatment with radiation. And I hope to have a CME about some of these with the Cayman Medical Group in the future. So again, head and neck cancer. Anything in the mouth or the head, behind the ears, treating that area, imagine, is harsh. You're going to have a sunburn in your mouth. If you're getting chemotherapy, combining chemotherapy with radiation is a tough treatment for patients with head and neck cancer. So for some patients, we are harping a lot about obesity, obesity, obesity. If you're on the other side of the scale where you're very thin or scrawny or MAGA, as we call you in Jamaica, treatment is even more difficult for MAGA people because they don't have any nutritional resource going in. So for those patients who are really scrawny or MAGA, they come in for treatment, we right up front give them a peg tube, a feeding tube into the stomach, because we know the treatment is going to cause them to lose pound. And if you're 5'5" and you're 90 pounds before treatment starts, then it's just going to get worse. So we have to maintain your nutritional status during the radiation treatment as well. So my big push for a lot of things, before I go here, Dr. Veit, I remember she said, you remember as a dentist because it rhymes with bite. See, I pay attention, I paid attention. This here is showing an oral cancer case, and this here is where the cancer is located in the mouth, back here. And for patients who dip and chew, they're at risk for this, as well as HPV. You know how they get HPV in the mouth, right? No? Okay, all right, so that being said, we have an issue with treating head and neck cancer patients because if they're not maintaining a healthy oral condition and seeing their dentist, I've had patients who are, well, HPV positive and in their 40s and haven't really been seeing the dentist and end up having to lose majority of their teeth for one reason or the other, because when you have radiation to the bones in that area, you don't want anyone going in to do any sort of dental surgery afterwards, because the bone is now weaker and you could get what's called also radiation necrosis. So I cannot emphasize more than Dr. Veit did last night that having a good dental hygiene is important as well. And the dentist is like really awesome for us because they detect some of these cancers for us and they help us to make molds to try and create the teeth, to protect the teeth for those who have healthy dentition. So now, one of the things I also do, as you notice that I'm with Question for Cancer Doctor, is I'm very much on the patient advocacy side. I want patients to understand what's going on. Radiation is even more taboo than cancer itself, if that's even possible. Because a lot of people don't know what radiation is, what radiation does, and they think about radiation and they think about the exposure. You go back to Nagasaki and Hiroshima, the bombing and things, and oh, I'm going to be burned real bad. It's not like that anymore. With the advent of improvement in technology comes the improvement in the treatment that we give, and the side effects are not like they used to be 30, 40 years ago. So to this end, one of the patient advocacy thing that we do, we know that folks, when they're diagnosed, they go they get information that are packets of reading material, and they don't want to read when they just get diagnosed. So one of the things Question for Cancer Doctor does is that they have videos that are compiled for different types of cancer. I did the breast and the prostate, so I know those are awesome. And within 40 minutes, you have an idea of, well, what's a biopsy? What are they going to do when they see my prostate biopsy? What does that mean? What's brachytherapy? They actually have these video clips that you can sit and watch and understand better. The other thing is, because I do so much breast cancer and I talk to patients, and they're like, Doc, I don't understand some of these things. And the book that we put together based on feedback is Cancer Advocacy for Women Simplified, where I just talk about what you can expect, what are the informations available, why is my pathology result taking so long? They did it a week ago. Why is it taking so long? What am I going to do? What's this radiation stuff? What's chemotherapy? I've never heard of it. So it kind of walks you through what you can expect, and then the questions for your cancer doctors. That's the thing. A lot of time folks are diagnosed with cancer and they have no clue what cancer is, much less what questions to ask. And so Question for Cancer Doctor have developed a little booklet that talk about prostate cancer questions to ask your doctor, kind of just help you through the process, just a starter for conversation. I know those will be available soon in November. Another confusing thing for the patient is that when they go on the internet, they really don't know what to eat when they're going through cancer. And there is a diet for everything. There's a diet for kidney cancer. There's diet and bladder cancer. There's food that kill cancer. There's diet for cancer prevention. There are 5 anti-cancer diet for brain cancer treatment, 6 diet tips for cancer prevention, and so much more information. They're like, look, what is it that we need to really eat? The U.S. Department of Agriculture and Health and Human Services put together a guideline that they have for a 15-year period, and this one, as you can see, came out 2015 to 2020. And in that guideline, they really just go through talking about what are the healthy eating habits to have. And it just shows here, I'm not sure how it projects, the spent in medical costs, diet, how much type 2 diabetes will cost, and how much heart disease will cost in billions. And yet 8 in 10 Americans think about, they don't know what to do or what to eat. They're confused, and who wouldn't be? So based on what was presented last night, again, they've made it simpler. They tell you what to eat. Now, one of the things, hey, don't forget the water. That's very important, right? We talk about everything else, but don't forget the water. So we talk about the fruits, vegetables, etc. I don't need to go through that because there's other physicians that did an awesome job in presenting that information. But one of the things that really strike me on their informatic graph here is that when you look at the healthy eating scores by age, when they're 2 to 5, they score 60%, and I'm thinking, well, that's because their parents are making them eat the healthy stuff, while they themselves may not be. And then ages 65 and plus, that's because the children is making their parents eating healthy, or they've just gotten smarter over the years. Now that they're 65 and older, they know to eat better. Whichever it may be, I thought it was actually quite impressive. And it shows here that return on investment is that you'll decrease heart disease, decrease type 2 diabetes, as well as cancer. So this is just showing you in tabular form what we discussed before, what the plate should look like, follow a healthy eating habit, focus on variety of nutrition, and shift to a healthier food and beverage choices. One of the things I tend to do for my son is, he knows if he's going to get some juice, 50% of it is going to be water, and I put some ice in it and stuff. So I dilute it down because there's so much sugar in these fruit juices. And sometimes the fruit juices, they say, oh, it's juice for kids, and it's only like 7-10% of it that actually have juice. The rest of it is sugar and flavor. My mantra is everything in moderation. See the guidelines, fix what you want to eat, but everything in moderation, including moderation, right? Just don't do the double Whopper thing. Try a Whopper Junior instead if you must have it. And everything you do, just do it in moderation. So coming down to the end, this is going to be a little bit more interactive. Talk about some cancer myths. No one in my family has cancer, so I do not have to worry about getting cancer. Is that true? Right? As we saw earlier, just from colon cancer alone, 70% of that is just sporadic. There's no familial indication for that. And the same, prostate cancer and others, if you're of African descent, we know you have an increased risk. So that is not very much associated with your family. If I get cancer, I'm going to die within a few months. People I know and I've heard of who were diagnosed with cancer went to the hospital and never came back out, and that's going to happen to me too. Is that true? So if you get your screening and stuff, like we show with a colonoscopy, and we're able to get that polyp when it's a polyp, or you get your pap smear when you're supposed to, and we get that early when it's just an early stage, or you get your mammogram when you're supposed to, and we get it when it's just a calcification or DCIS, then that's not the issue. But if you scare yourself into staying away, then that may be truer than you want it to be. So cancer feeds on sugar, so if I stop eating sugar, that will starve and eventually kill the cancer. Oh, I'm sorry. People weren't sure about that. That's a big myth. I had a patient who actually thought this was true and stopped eating sugar and passed out. Okay? So the concept of this was that because the cancer cell is multiplying so much faster, that it requires a lot of energy. Energy comes in sugar, and so they figure that if you don't eat sugar, then you won't feed the cancer. But there are other things in your body that's working all the time that needs this carbohydrate. They need this sugar. Your brain, well, yes, all the time. It's going, right? Your heart, it's pumping. It needs that. So that is not true. That's a myth. You don't starve the cancer by not eating sugar. It's going to use whatever your body resources have, and you want to make sure, again, that you're in good health. Now, last one we look at, I'm not at risk for colorectal cancer. Why do I need a colonoscopy, right? I can do a colon cleanse, and that's natural. Everybody's into this natural thing now. And it does the same thing. Does it do the same thing? I'm sorry? Okay, my job here is done. So a colon cleanse, it doesn't see what's going on in your colon, right? We want to see what's going on. If something is there, we want to remove it. And so that's where the colonoscopy really make a big difference in doing that. So, again, what are you willing to do? Last stress, just as like a relay. This is, I was the anchor, so here we go. If there is something you could do to help you live a longer, healthier life, longer, healthier. There are a lot of folks who are living a little bit longer, 70, and then they open their pill box or they bring in their medication list, right? So there's a difference, as was discussed earlier this morning by my colleague, that living a longer life, not only you want it to be longer, but you want it to be healthier, right? So in order to do that, we've been emphasizing a lot about you need to do this, you need to do that, but how do you do that? You got to train your brain. You have to make a change, and that's going to include taking some small steps. Let's start with this. You can read out loud if you want. What's the color? What's the first color? Next. Just keep going through it. All right, here we go. Let's do this again. Colorblind folks in here. All right. Okay, good. Now, let's do this again. Ready? I want you to snap into it. Let's go. Ready? Let's go. Happens every time. What's going on? The left is trying to say the word, left side of your brain, and the right side of your brain is actually trying to say the color. So instead of saying yellow, you want to say red, and instead of saying red, you want to say black. But if you take your time and you go through it now and you say yellow, red, purple, black, green, orange, yellow, I can't see that one, and then blue, right? It takes some thinking and mind adjustment, and it's the same thing with change, with your health. You have to take it slow. You can't go from eating burgers and fries and stuff regularly to then becoming a vegetarian. It's not going to work. Or you're not going to just go from smoking 3 packs a day to quitting dry bone. That usually doesn't work. So it's a progressive thing, and you're going to have to train your brain to do this. Usually it takes 30 days. If you're able to do something for 30 days, so swap one thing out. So, okay, instead of having a double Mac or whatever it's called, see, I don't eat that stuff. So instead of having a double Whopper then, let's have a Whopper Junior and have an apple with it, right? And instead of grabbing for that Doritos, let's eat a piece of string cheese with some celery or something. Do some changes, small steps out. And if you're able to do this every 30 days, you make a small change, park a little bit farther, walk a little bit longer, take the stairs instead of the elevator. All these little changes contribute to making a healthier lifestyle change. So it won't be this drastic diet you only do for 3 weeks. You're just going to go right back yo-yo. You want to make it something more permanent. One of my favorite sayings is from one of my mentors, Dr. Wayne Dyer. And what he says is, when you change the way you look at things, the things you look at change. And that includes yourself. If you start to having a better perspective about who you are and what you want to attain, and you want to live longer and a healthier life, then you're going to do the things towards that. What do you see? What do you see? I'm sorry? 2 people facing each other, and you see? Oh, nobody see the vase? So there's a vase right here. See that? Or it could be 2 people facing each other. It's all a matter of perspective. So, eating some celery with some dip may not taste right, but if you just try it for a little bit, it can make a difference, right? A perception of what's healthy. If it's healthy, that doesn't mean it has to taste bland, as you heard last night. You could put some seasoning on it. So what's this? What do you see? I'm sorry? Somebody is playing a saxophone, right? But then there's a woman right here, the eyes and her hair with a shadow to the side. You can make these changes. I'm doing this to make a point, emphasizing that the stuff that's good for you is not all bad, right? And then here is one of the last one here. What do you see? Two old people. Two old people. Yeah, but for those who only see the two old people, take a closer look. You'll see a man sitting here, right? And this person over here playing the guitar, and the sombrero, the hats, and their elbows are forming the nose, and the mouth here is actually the waistline. If we point out to you what's there to be seen, you can see it. If we tell you what you can eat, and you make the steps toward these changes, you can do it. Now, for my last one here, this has to do with treatment, right? See it different. No 3, no 4, which is it, right? Right? It depends on your perspective what side you're looking at. Yeah, but it's the same drawing, you can barely tell. So I would like to close out with this in saying that, you know, we are constantly changing in the medical field. And so today we have chemotherapy, radiation, and, you know, surgery, and now they're getting all these targeted therapies that they can use to target what's on the cell, and it's an ongoing change. However, what I want to leave with you as well is that if you are from the Caribbean and you're prone to doing the stuff your grandma did and scrape up some stuff and you eat this and you do your moringa and you blend up some guineas with some eggs and some soursop and send your kids off to church in the morning, you know, that stuff may not really harm you if you're going along with what's traditionally known to work. Talk to your doctors, though, because you don't want, I mean, there's something that's easy. I don't ever have to tell my patients who drink a lot when I'm treating his mouth for oral cancer that he doesn't have to drink. I don't have to tell him not to drink. You know why? Because the radiation is going to fix that once he starts getting oral sores. You try to drink, it's just going to burn. And so, you know, sometimes, though, we have to try to help patients and help others along the way to say, these are some things to consider. And not push too hard, but just make encouragement about changing the perception of what we know and what we grew up with, the fried chicken and the oxtail and the curry goat and all that stuff. We could still have some of that, but eat some apples and blend up some things. And Foodie Physician was really good last night. I'm gonna try some of that stuff. See what you've never used before. Spice up some things a little bit. Just make a different change. So we covered a lot today. We talk about cancer statistics, best health practices, you know, down to the myths, which is a big thing for us. And so in my acknowledgement, I'd like to thank the Cayman government, the Cayman Island Health Conference Committee for choosing me to be here to do this presentation. Tower, specifically Ms. Elisa and Natalie for making my transition and getting here from the DC area so easy. And the leadership of Question for Cancer Doctors for allowing me to be here. Thank you so much for your time and attention. Any questions? Thank you.